Professor Schaller, we have to thank you very much. Best regards from Tel Aviv to Tübingen.
Yes.
Here the weather is nice. It's a beautiful day. And thank you making the whole story round. It was an excellent talk. And you gave us a lot of new information, which we could share now with them. Professor Schaller, we will start with questions. We have already sampled a lot for my talk. I think in the time in between, there will also questions coming up for you. So I will start now answering my questions, yeah?
Okay.
So one of the questions which came up was, if one can combine adapalene benzoyl peroxide plus a topical doxycycline gel, well, I wouldn't recommend that. First of all, we kill the Cutibacterium acnes with the BPO. So why putting doxycycline gel in again? The other point is topical doxycycline enhances phototoxicity. We do not know, on the other hand, if doxycycline topically really is anti-inflammatory as on the systemic route. So I wouldn't recommend that. Another question is, what about the use of retinoids in pregnancies? First of all, if someone is becoming pregnant under the treatment with a retinoid, you don't need to make any interruption. You stop exposure, that's all. There is one very important study which was done in the past. There were two cohorts, pregnant women who were exposed to the use of tretinoin and those not exposed. The outcome of these prospective large cohort studies was the number of events, adverse events on pregnancy was absolutely the same between the two groups. So it's just a safety reason to stop, but not more. There's really a discussion between scientists about the necessity. Then another question is about acne neonatorum and acne infantum and the use of epiduo. Well, this is not an easy question because we don't have any evidence-based data on this. However, one can use epiduo every second or third day. And you can also try a short contact use. Be aware not to go too close to the eyes, to the nostrils, to the mouth. And you have to be aware of the fact that the child may probably go with the hands in the face and it smears around. So that makes the thing a little bit difficult. But all in all, first of all, adapalene alone, I have no problems. With the BPO and a little bit more irritation to an infant skin, go to every other day on short contact. Then another question was, which kind of combined medicine do you have? Well, first of all, we have to divide in two parts. This is the combined fixed treatments, this is BPO and adapalene. And on the other hand is the combination topically and systemic. And the evidence-based data are in favor for fixed combinations with BPO and low-dose doxycycline plus the combination. This is ideal. Another question was, is there any allergy to BPO adapalene? So we are not aware of allergy against the third generation retinoid. And BPO, we have seen in the past contact allergies, but it was mostly due to treatment of leg ulcers with 10%, the number of BPO 2.5% is very, very low. It does not really play a role. Yeah. Another question is, we have to scroll a little bit that I can read it. A lot of patients have irritation after the use, and they even like to prefer and to discontinue despite quite good outcomes. So my recommendation is use in the morning and maybe over day Cetaphil as a moisturizer, and there are less effects. Something is very important: not overwashing the skin. The more you wash the skin, the more you influence the usual microbiota, aside from C. acnes, and you remove too much of the seborrhea, and don't use additional alcoholic astringens or something like that. And put the fingers out of the face, don't go in the sun. And if you are working in a very dry atmosphere of an office, you may use the moisturizer oftentimes. So these were the most prevailing questions coming in to me. And we will have now a look if there are questions coming for you, Professor Schaller. We are looking forward if they just appear on your screen.
Yes, there are some questions. One question is, could the ivermectin cream be used during pregnancy? So this is, I think, if you look at the patient information, they say no. That's clear. But ivermectin is a macrolide, and macrolides are safe in pregnancy. And ivermectin pills are distributed worldwide in Africa for the treatment of onchocercosis. So there are no hints or no data showing an effect, a bad effect of ivermectin cream during pregnancy, but every doctor has to decide this by its own. So I think it's safe, but if you recommend this and the child has a problem, you have a problem. But I think it's a safe medication. What do you think, Professor Gollnick?
Well, I can follow you, absolutely. I'm in particular your example from treatment of tropic diseases with ivermectin. That's proven, and we have also ivermectin in endemic scabies, orally, and there is no, as far as I know, evidence that one has to be absolutely sure of any pregnancy. Yeah? Yeah. Do you agree with me?
I agree with you, but it depends on the personal situation and on the situation with the patient. Another question is, could the ivermectin cream used more than 1 year? Yes, certainly it could be used in more than 1 year. It's a very safe and efficient treatment. It is necessary to use sun protection creams while using ivermectin cream. I think it's necessary because the disease is rosacea, and rosacea will be not better, but it worse if it is a sun influence. So it's not necessary to use it because you use ivermectin cream, but it's necessary to use it because rosacea become worse under sun influence. So can we initiate treatment with topical ivermectin as many times a rosacea relapses? Will we have same good results after reinitiation? I think so. So I have some patients with stopped treatment and they came 1 year later and I started again with the rosacea treatment by ivermectin and it worked. But there's another question about isotretinoin. I don't know if you asked this before, a combination of Epiduo and Cetaphil.
Well, I'm convinced that one can start with ivermectin immediately And if you have the impression that the patients need, in addition, some Cetaphil, well, it's up to them. Ivermectin at all is not irritating. So this component of BPO is really to be neglected with the treatment with ivermectin.
Yeah, there's another question. Are there any validated studies discussing on the rosacea and corticosteroids as method of treatment? So I think there are a lot of knowledge that we should not use corticosteroids for the treatment of rosacea, for the normal rosacea, the papus and the pustule, because there's also steroid-induced rosacea. So I would not recommend to do this. Can we use ivermectin for pregnant women? So we discussed this before. And there are some treatments question for peeling. And what about result maintenance? Let me answer this before. So I recommend my patients to have a maintenance treatment. So if they are completely clear, they should use ivermectin twice a week or once a week.
May I ask you something, Professor Schaller? That's very interesting that you are pointing towards maintenance, because obviously the elder the population is growing, the larger the follicles are becoming, there is more space for settling of the Demodex mites. Did you look in your studies also if the younger or the elder are responding faster, or the all-over results are better? Or is this equally going over all ages?
In my opinion, it's equally going over all ages at the moment, but we didn't look at these subgroups, I have to admit. But I think there are some typical patients responding better to ivermectin. That's a patient without seborrhea. For me, seborrhea patient with seborrhea and rosacea, they did not good. I think isotretinoin would be a very good treatment. And these are patients with the spikes, with this follicular spikes, they respond very well. But I have not seen there's a difference because of the age of the patients.
Would you recommend in the more severe cases, which also have a little bit of this granulomatous type of rosacea with large lesions, externally then ivermectin, and systemically with doxycycline, most probably combining a double effect on the anti-inflammatory mechanisms?
I think that if you have a granulomatous rosacea, it's sometimes very hard to treat. And so I would recommend the combination of both, ivermectin topically with isotretinoin or with doxycycline. And most important is to discuss with the patient that the treatment a better result will be not before 4 months.
Thank you. Yeah, I don't see that other questions have coming in, also not on your screen, Professor Schaller. No more.
I have one question about chemical peeling for acne treatment, and no more other questions.
Coming up, chemical peeling, well, it refers to me. Well, chemical peeling is nothing for number A, intervention in the treatment regimen. It is for maintenance and for adjunctive measures. Peeling alone is not effective. I was not going into the treatment of lasers and photodynamic therapy. There's a lot of publications, but there's a small case studies, not really long-term, double-blind, as far as it is possible, good controlled studies. So I would not recommend that. Well, Professor Schaller and myself, we thank you at home in your office for listening to us. And we hope that we could bring over the messages. And we wish you a relaxed evening. And thank you very much. And goodbye.
Goodbye. Thank you very much.